Hi, I'm Shawn. I'm the coordinator for the Provincial Elimination Program in PEI. So today we're going to talk about Rapid Stop Hep C. So anybody that's or has been hanging around with Dr. Lisa Barrett for any amount of time has encountered this diagram before. This is our plan, essentially our strategy for eliminating Hep C in Prince Edward Island. Right now, we're already doing the automatic referrals to the provincial program. We are acting as a centralized triage and workup referrals for the appropriate providers. So right now, what we're really focusing on is the treatment timing and then the education component. So even with a very structured organization, we do have barriers to treatment initiation. The big one with IV drug users in particular is the lack of baseline blood work. It's difficult to perform phlebotomy with them. There is limited engagement in a typical clinical situation. A fair amount of our patient population, they don't actually have family practitioners, and generally the methadone clinics are going to be the ideal place to encounter them. There's generally going to be a lack of trust with providers, be they burned before, they've been caught double doctoring. There's various scenarios that have played out, and generally they just don't want to engage. And then there's the lack of immediate drug starts, because it turns out if you don't have medication on hand for an individual right away, they don't really care. So the big question is, does same-day treatment start for eligible individuals, change engagement and other care? And more importantly, is it safe? So the streamlining of Hep C appointments is something that we've really tried to focus in on. And prior to them seeing the prescribing physician, we tried to identify individuals who are treatment naive, non-cirrhotic, any genotype, it really doesn't matter, as long as they have some history or indication that they do have HCV viremia. We do attempt to perform baseline blood work. It's kind of necessary at times. We like to have that going into it, and we do have a provincial DIS or drug information system that we do like to reference and to identify interactions prior to meeting with these individuals, at which point medication is dispensed from the provincial pharmacy and is delivered to the opiate substitution clinics. The appointment, they meet with the provider, their prescribing physician. It's going to be either at the opiate substitution clinic or at a special Hep C clinic at public health, depending on the patient preference. There's going to be a brief history and physical, education component, a confirmation of the medications, any additional substances they might be taking, and more importantly, they leave with a goodie bag of medication at that visit. So this is actually the second phase of our program in Prince Edward Island. It started off early in 2015. There was 2 prescribers, 1 nurse, and not very much public funding for the medication. So there was 2 patients treated at that point in time. Moving into late 2015, they did develop policy. There was public coverage for patients. They still had 2 prescribers and 1 dedicated nurse full-time, with a whole bunch of patient support. In that time period, 24-ish months, 170 patients were treated. Very, very stringent framework, a whole lot of appointments, very good at identifying individuals who are of the higher cirrhosis and getting them on treatment as soon as possible. Phase 2 started roughly a year ago. And we actually decreased the amount of prescribers we had. We went down to 1, and we had a whole lot of auxiliary individuals. 1 coordinator, and now more recently a nurse and an admin. And in this time frame, we actually managed to start 122 patients, particularly of the high-risk group, IV drug users actively. But the big take-home, I guess, from this slide is that with a small population in Prince Edward Island, estimated 1,000 patients with hepatitis C, we've already addressed and started on treatment 294. So this is just a general demographics. We do have a relatively young cohort of patients, and predominantly male. Most of them are on opiate replacement therapy. We primarily do most of our work in the methadone clinics, and it's a good place to interact with them. There is a significant amount of IV drug use, both past and current, and most of them do endorse poly substance use. So the big question is, that was really loud. is it safe and is it effective? And of the 124 patients we started using this method, 122 were eligible for treatment, 2 were cirrhotics and had to be referred to gastroenterology. No, 117 were started on that first visit. The 5 individuals who weren't started, they were due secondary to pregnancy or medication interactions that required a washout period prior to safely commencing therapy. We have had 3 patients discontinue primarily for psychosocial reasons. 1 patient was lost to follow-up, although she did come back to us in the end, which was nice. The biggest, I guess, indication is that 58 of 61 patients who have achieved SVR12 or reached that point in time were cured. The 3 patients who weren't, mostly it was compliance. This graph is really the question, do they seem to be more engaged after they've treated, or are they more engaged with their opiate replacement program? And generally it seems that they are. 60% of them did seem to have better attendance rates at their opiate or methadone appointments. The one at the bottom all the way up, he's our prodigy. He seems very invested at this point in time. But more importantly, and it doesn't really articulate or show very well in this data, is that we had 4 people that we contacted strictly for hepatitis C that chose to meet us at the methadone clinic. And after meeting us there, they decided to start the methadone program, or Suboxone more appropriately. And that really does give me all the warm and fuzzy feelings. And this is more or less the same data, but it does just show you how precarious these individuals can be in their lifestyle. They can have great attendance 1 week, and then all of a sudden they drop back down to not coming so much. But it does seem to affect all spectrums, whether they're going to be non-compliant or not. But as a general rule, they do seem to have better attendance. So in conclusion, the pre-visit blood work, medication review, and pre-genotype starts and on-site medication appear to be useful tools to allow rapid treatment starts. And same-day starts may increase the engagement in methadone clinics visits, but this needs to be demonstrated in more generalized vulnerable populations. So for acknowledgements, I'd really like to thank PEI government in particular. They are funding the program. It's great. Stacey Burns, she provided a lot of the data in terms of individuals who previously tested positive. Dr. Heather Morrison, our Chief Public Health Officer. Pam Hensby, she's a nurse at the methadone clinic. She gives me calls probably 4 or 5 times a day, just telling me where patients are and how I can contact them. Public health is obviously imperative. Dr. Lisa Barrett is Dr. Lisa Barrett. And then Dr. George Crothers and Peter Hooley, who have, I guess, tolerated us for now. Thank you.
It's okay. All right. Does anyone have any questions?
Quick one, impressive results. This is in the context of opioid replacement therapy. So has crystal meth hit PEI in the Maritimes?
Oh, absolutely.
Yeah?
Yeah.
So how do you think that's going to change the dynamics, for lack of a better word?
I'm not really sure. This is something that's kept me up at night, wondering how exactly you're going to get into that community. There's certain avenues. I mean, there is a certain amount of polysubstance abuse, and generally they are intertwined to a certain degree. One of the things we have been trying is to disseminate my phone number, my cell phone number, to as many people as possible. And we just randomly get calls from individuals, be they on opiates or on meth or not on anything at all. They just happen to know a guy who knows a guy. So that's been a good method of recruitment. There was talk initially of testing in the ERs periodically to see individuals on meth appear in stimulant-induced psychosis, which could be a good way of making contact, but generally they don't really remember those visits. So.
Thank you. All right. On behalf of my co-chair, Lisa Barrett, thank you very much to the speakers and to the audience for your attention. And the coffee break has begun.